All right, good evening, everyone. My name is Carolyn Wilhelm, and along with the SOPE Education Committee and my co-chair, Don Park, we would like to welcome you to this evening's session where we're going to be seeing some captivating cases. We would like to thank our sponsors. Bailey, if you can go to the next slide. Wonderful. So we'd like to thank our sponsors, Seattle Children's, Lucille Packard Children's Hospital at Stanford, Nemours Children's Health, Cincinnati Children's, Healthcare Kentucky Children's Hospital, Ann and Robert H. Lurie Children's Hospital of Chicago, Rady Children's Hospital at San Diego, Akron Children's as well. So Dawn will be introducing our moderators for the session and our speakers.
Yes, thanks, Carolyn. Good evening, everybody. I'm really excited that you're here. I'm excited to review some of these cases that we have tonight. So my moderator tonight that's going to be helping me out is Alice Hackett. She is a pediatric and fetal cardiologist at Nemours Children's. So Alice, if you would like to start, it's all yours.
Yeah, sure. So our first case is from Bernadette Richards. She is a longtime sonographer and current program manager of the Echo Lab at Nationwide Children's Hospital.
Okay, thank you. Thanks for letting me present a case today. This is what I'm calling International Edition. This case was from September of this year as part of a medical mission trip with HeartCare International, which is a nonprofit that not only provides pediatric cardiac surgery, but also trains local teams related to pediatric cardiac surgery and ICU. If you have any year-end giving left to do, I would like to suggest giving to HeartCare. This was in Chiapas, Mexico, which is the southern.
We don't see your slide. I don't see your slides.
Uh-oh. Shared my screen. Let's see. Bailey, am I allowed to share? It said it would stop everybody else.
Yes, you can. You can click that.
There you go. It's starting to share now.
Good.
Yep. We've got the globe. Okay.
All right. Go back here. We've got the globe. We'll just keep going from there. Let's see. I'm not able to navigate here. Okay, so the flow of each week is determined on an overlapping day where the screen team and the surgical team get together. So there's a little bit of a plan to do about 20 operations the week that we're there. As a sonographer, my role was to press buttons for the surgeon when they're doing epicardial imaging, as there's not really any TEE while we're there. Also providing post-op echoes in the ICU. It is really a different setting, different machine than I'm used to. There's no orders, there's no PAC system, so access to prior images is pretty limited. And then I kind of show the images to the surgeon directly from the machine. Unfortunately, I don't speak Spanish yet, so there's a language barrier, not only between me and patient families and the local team, but also between me and the machine, which has all of its buttons in Spanish. Ergonomics are out the door, and the team dynamics are different. These aren't the people that you're working with every day. It's people from all over the country, and they're just trying to get the job done. So surprise, surprise. Middle of the week, we're trucking along with our cases, and our coordinator got a call about a patient who was born 19 days earlier at a rural hospital about 7 hours away, who at 5 days of life was transferred to hospital number 2 because she was not well. She was evaluated by a pediatric cardiologist who told the family that there was nothing to be done and that she was going to die. 2 weeks later, she was alive, and the team at that hospital heard that HeartCare International was at another hospital, so they put her on a 6-hour ambulance ride and dropped her off at our hospital. I would like to note that her parents did give me permission to present this case, and they also provided some pictures of her and gave us permission to show the pictures. So upon arrival in the ER, she was in distress and quite blue, sitting in the mid-50s. So we started the echo. We didn't record all the images. Like I said, all the images are stored on the machine itself. So we tend to just record pertinent images to show the surgeon. So I took a little tour of the heart and noted right away that the right heart was dilated and that there was a right to left shunt across the ASD, leading me to believe this was potentially TAPVR. At that point, I looked for abnormal venous drainage in the liver, didn't find any. The coronary sinus was normal size. There was no whale tail sign. So went up to the notch looking for a vertical vein, both on the left side and the right side. Couldn't find a traditional vertical vein, but did notice this pretty dilated SVC. Then went back down to subcostal to kind of start a little bit in a normal protocol after my tour. Got super distracted by this reversal of flow in the abdominal aorta, something I'm not used to seeing in patients with TAPVR. So I was trying to go back to the drawing board and figure out what's going on. Why is there so much flow reversal? In this subcostal coronal view, you can nicely see the left atrium and the venous confluence behind the left atrium there. And then again, at the end of the sweep, that big dilated SVC. Using color Doppler here, you can see the SVC and the aorta and this odd color connection, which almost appears to be between the aorta and SVC. Moving on to subcostal sagittal, it allowed us to really delineate that this was really the confluence and not the aorta there, almost directly communicating with the SVC, taking the long route to the left atrium. So pulmonary venous return here, going to the SVC down to the right atrium across the atrial septum into the left atrium. And again, a little bit of a better image of this confluence here and the connection to the SVC. Nice obstructive flow pattern. This was a second distraction. All throughout the echo, when I was looking for VSDs or any additional findings, there was really prominent color flow Doppler signals in the coronaries. So I was super distracted still about this flow reversal, and I may have asked Siri to text my friend Dawn to share our list of 20 things that potentially could be causing this flow reversal. So this patient didn't have aortic regurgitation. They didn't have a left to right ductus. They may have had a cerebral AVM, not sure, or these may just be a result of shock. So I'm going to skip this one. This is just another picture of the obstruction and the communication between the connecting vein and the SVC. In these pictures, you can see the left veins coming to the confluence, and just another picture of that little connection between the confluence and the SVC. Same thing in this modified subcostal sagittal. You have a confluence here and the little connection with the SVC. So our summary about a half hour in or at the end of the echo is that we did in fact have an unusual connecting vein, which was obstructed, TAPVR. I was still really distracted by this flow reversal in the aorta, and just of note, there was increased coronary flow. So next we go back to our kind of group place, and the surgeon comes out from his case, and we said, surprise. You're not going to do the case you thought you were going to do this afternoon. And we reviewed it together, and he did ask me at this time, is there a PDA? And I said, no. And he took the patient to the operating room at 4:30 p.m. This was just not a timeline that I was used to in my institution. I was hovering in the OR because I was curious and had nothing else to do. And he said, oh, there is a big PDA, which of course I was not feeling very happy about, and went back and looked at my pictures. And sure enough, sorry, this is playing choppy. Sure enough, there was a big PDA, but it was blue and it was right to left, consistent with the patient's actual physiology. But at the time I was distracted looking for a left to right ductus because of that aortic reversal of flow. So that was kind of sad for me. But he did say that the connecting vein was exactly as described in the same location, allowed me to take a picture, which I'll show on the next slide. And by 8:30 p.m., this patient was headed to the ICU. this was just like an incredible timeline for our team, like 2 p.m. to 8:30 p.m. It was all about this sick baby, and she did really well in the operating room. This is a surgical picture. He was kind of moving the heart a little bit so that I could see the confluence, which is noted with the yellow arrow. The SVC is in the black arrow, and then the purple arrow is that little connecting vein, almost just like we saw it on the echo. I will say that I did 2 post-op echoes on this baby in the ICU. No reversal of flow in the aorta anymore. Coronary flow is normal. I mean, you could almost not even see the surgical repair. It looked just like a normal heart. So the final case summary is this patient did have a 19-day-old patient with obstructed TAPVR with the pulmonary hypertension in the right to left ductus. The patient did have cerebral vasodilation, which is a compensatory mechanism to increase blood flow to the brain to maintain oxygen delivery, which led to the flow reversal in the aorta. And elevated filling pressures likely leading to that pulmonary coronary Doppler signal. Sonographer notes for this study: obviously stay focused during urgent cases, get the diagnosis, and when encountering distractions, try to sort that out. Is this really a distraction? Does this go along with the diagnosis and not getting that tunnel vision like I got looking for a left to right ductus? This is my favorite slide. Here's mom and dad taking her home less than 2 weeks after the operation. She's just a little over a month old in this picture, and these parents were told that she was going to die. So this is the happiest parents you'll ever see. And they keep sending us pictures. Like every 2 weeks, they send us more pictures of happy little pink baby. So with that, I hope I stayed on time.
Thanks, Bernadette. I think it was a really good case. When we were discussing and texting back and forth, I have like a list of 20 things that causes a flow reversal. Brain sparing, I've seen on fetal echo. I don't see it very often on peds echo. And so that wasn't like at the top of the list. It was more some of the other stuff we were worried about. And by the end, I'm like, this kid is I've never seen a 19-day-old with obstructed veins before. And so to see brain sparing on a pediatric echo is pretty impressive, but great story. I love it. Thank you. All right, so next is Dr. Jenna Schermerhorn. She is currently an advanced non-invasive cardiac imaging fellow at Children's Mercy Hospital in Kansas City. Her primary focus this year is on fetal echo as well as transesophageal and 3D echocardiography. So Jenna, it's your turn.
All right, thank you very much. Let me share my screen. Okay, so I'm going to present a 7-month-old male who presented to our emergency room with cough, congestion, and increased work of breathing. The parents had reported 4 days of cough, congestion, and runny nose. They had tried albuterol at home with some improvement, but the day prior to presentation, he started to have decreased PO intake despite using the nose Frida prior to feeds. And on day of presentation, he had an acute increased work of breathing and some concern for bluish discoloration around the lips, prompting presentation to our emergency room. He has a past medical history of eczema. He also had a history of multiple viral respiratory infections, including a previous hospitalization at 4 months of age for human metapneumovirus bronchiolitis and concern for left lower lobe pneumonia. He also had a recent history of a COVID infection a month prior. Home medications were just albuterol as needed, and family history was notable for a fatherhood with childhood asthma, but otherwise what family history was unremarkable. The baby lives at home with parents and an older sibling. There was no tobacco exposure, and his immunizations were delayed. He had missed his 6-month-old vaccine secondary to recurrent viral illnesses. So on initial evaluation in our emergency room, he was noted to be tachycardic, tachypnic, but normally saturated and afebrile. His cardiovascular exam was notable for a regular rate and rhythm, no murmur, no gallop, and good capillary refill. On pulmonary exam, the patient was noted to be tachypnic with moderate work of breathing, intermittent grunting, diffuse wheezing, and a prolonged expiratory phase. And his ENT exam was overall unremarkable. He was administered albuterol, nasal suctioning, and given a normal saline bolus with some improvement, and then administered a duoneb and oral dexamethasone. However, following that, he continued to have an increase in his respiratory rate to the 70s, so was initiated on high flow nasal cannula, and did not improve on that, and so was transitioned to BiPAP and admitted to the pediatric ICU. The initial laboratory evaluation, the respiratory panel was positive for adenovirus and rhinoenterovirus. Initial venous gas showed a metabolic acidosis with respiratory compensation. Electrolytes and LFTs were overall unremarkable. CRP was mildly elevated. And then more importantly, the troponin was elevated at 0.34 and the NT-proBNP was significantly elevated at 36,000. Given this in the recent history of COVID infection, an EKG was obtained, which demonstrated sinus tachycardia, right axis deviation, biventricular hypertrophy, and some nonspecific ST and T wave abnormalities. Tier 2 MISC labs were ordered and an echo was obtained to rule out myocarditis. And his initial x-ray also showed some increased interstitial prominence and hazy airspace opacification and kind of an upper limit normal cardiac size. So on our initial echo on our 4-chamber, we saw a dilated right atrium and right ventricle. You can see there's right ventricular hypertrophy and RV systolic dysfunction. The LV was normal in size with normal function. And then as you focus and you start to see this echo bright membrane within the left atrium. So on dedicated imaging of the left atrium, we begin to see this echo bright curvilinear membrane within the left atrium above the mitral valve. And as we sweep anteriorly, we can see that this membrane here is separate from the mitral valve. And so this raised our concern for core triatriatum sinister. And then taking a look at the mitral valve, there was this trivial mitral regurgitation. And then as we sweep anteriorly, we see this turbulent flow coming from this proximal chamber into our true left atrial chamber. And on other imaging, we noticed that there was normal pulmonary venous return into this proximal chamber. And then over here is an apical 2-chamber view. This is posterior, anterior. This is our left atrial appendage. And you can again see that there's this curvilinear echo bright membrane within the left atrium that is above the left atrial appendage. It is not adherent to the mitral valve annulus. There's good mobility of the mitral valve leaflets. And it has this windsock-like appearance, and you can see it move towards the mitral valve in diastole. So this further confirmed our suspicion for core triatriatum sinister. And then as we look in our parasternal short axis view, again, you see this echo bright membrane above the left or proximal to the left atrial appendage. And you start to see some hints of some small fenestrations within that membrane. And these are just still images to show this membrane within the left atrium. So this is the membrane, left atrial appendage, left atrium, pulmonary venous chamber, atrial septum, and then you can see a small fenestration, and with color you can see turbulent flow across that fenestration. And this is just a sweep more cephalad, and you can see an additional small fenestration here. And in other views, we did have a PFO in the atrial septum that was in the region of the true left atrium. And so on Doppler interrogation of flow across those small fenestrations, we had a mean gradient of 24, raising significant concern for significant obstruction of the core triatriatum sinister. And on pulmonary venous Doppler, you can see prominent A wave reversal, again, further reinforcing pulmonary vein obstruction. Taking a look at our tricuspid valve, you can see there's moderate tricuspid regurgitation. and our estimated RV pressure based on that TR jet was suprasystemic at more than 5 meters per second with a systolic blood pressure of 67/42. So following the diagnosis of obstructed core triatriatum sinister, the patient was transferred to the CICU in preparation for surgical intervention. The baby continued to have acute respiratory failure along with progressive metabolic acidosis, presumed to be due to inadequate cardiac output in the setting of increased metabolic demands, and he was placed on VA ECMO. And then following discussion in our surgical conference, it was decided the patient should undergo surgical intervention. And on day of 8, the day of illness 8, the patient was taken to the OR where he underwent choroid triatriatum repair and ECMO decannulation. These are just some nice TEE images showing a 4-chamber view and then a modified 2-chamber view, again, demonstrating that curvilinear windsock-like membrane within the left atrium that is proximal to the left atrial appendage, not adherent to the mitral valve annulus. Postoperatively, the patient returned to the CICU on inhaled nitric oxide and minimal inotropic support. He overall had an uneventful post-op course, albeit it being prolonged due to prolonged mechanical ventilation, weaning of neurosedative medications, and optimization of PO intake. And he was discharged home on post-op day number 25. And he's now a 3-year-old boy who follows with our cardiology team, who reports he remains asymptomatic from a cardiac standpoint. He's very active and growing and developing appropriately. So just to wrap up, core triatriatum sinister typically presents within the first few years of life, but some patients may be asymptomatic for decades. The clinical symptoms include a history of breathlessness, frequent respiratory infections, and pneumonia. Physical exam is consistent with a murmur that mimics mitral stenosis with a soft blowing systolic murmur along the left sternal border, signs of pulmonary hypertension with a loud P2 component and RV heave. And in classic core triatriatum sinister, the embryologic theory is that there's failure of incorporation of the common pulmonary vein into the left atrium. And then this pulmonary venous chamber this proximal chamber usually contains all 4 pulmonary veins. The true left atrium communicates with the left atrial appendage, and in most cases, the true left atrium has a fossa ovalis lying between it and the right atrium. And then you get secondary right atrial and right ventricular dilation with or without ventricular dysfunction. And that's all I have.
Thank you, Jenna. That was a great case of something that we don't see too often. So that was really wonderful to hear. Our next presenter is going to be Dr. Stephanie Samples. She's a pediatric and fetal cardiologist at Lurie Children's Hospital and serves as the Associate Echo Lab Director for Clinical Operations and Quality Improvement. And just to remind everybody, if you have any questions for these cases, go ahead and put them in the chat and we can address them after we finish.
Thank you, Alice. So I'm going to be presenting a fetal case. So this is a 22-year-old G1 who actually came for fetal echocardiography at about 25 and 5 weeks of gestation due to concern for congenital heart disease. There was really no significant family history. Taking prenatal vitamins. She had them. This first image on the left is our situs sweep, which we do using the Cordis method. So you can see as we do our initial turn of the probe, the spine is down. So this is the left side on the bottom of the screen and the right side on the upper side of the screen. You can already appreciate we obviously have multiple things going on in this fetal heart. So we'll look at them a little closer here, sweep through the heart with color compare. You can appreciate that we have what looks to be an AV canal with a common AV valve and a large ASD and disty. As we sweep forward, you see there's a single outflow coming out of the right ventricle. And there's obviously a lot of other vessels happening in here, which we'll interrogate a little bit better in some upcoming images. So obviously this is a very complex heart. When we focus on the four-chamber view of the heart, again, you can see this looks like a complete AV canal. But one thing to point out is the distance between the left atrium here and the descending aorta. So in fetal echocardiography, increased distance between the descending aorta and the heart is actually associated with anomalous pulmonary venous drainage. And if you look closely, you can actually see this circular structure here, which is posterior to the left atrium. When we put color flow over that with a low Nyquist limit, we can very clearly see both right and left pulmonary veins draining into this confluence, which is posterior to the left atrium and does not appear to communicate with the left atrium at all, which is consistent with total anomalous pulmonary venous return. So then we turned our attention to where the confluence itself is draining. And so these are two similar sweeps where you can follow these pulmonary veins draining into the confluence, and then it goes up superiorly and drains into the SVC. Again, you can see the same thing on this side. Again, the Nyquist limit is very low, so there's a lot of turbulence, but we were very clearly able to demonstrate where these veins were draining into the SVC. As we focus more on where the veins entered, now with a higher Nyquist limit, you can appreciate that there's a lot of turbulence just a little proximal to its insertion into the SVC. When we Doppler that, we get this obstructive pattern with a mean gradient of 4, which in fetal world is very significant given the only 10 to 20% of cardiac output prenatally goes through the lungs. So this is a very significant gradient at this point in time. When we did our sagittal arch images, you can appreciate that there is a vertical PDA supplying the branch pulmonary arteries, which are confluents. And then you can start to see this sort of turbulent flow very close to that PDA as we sweep from right to left, which is the obstruction in the vertical vein. So at this point, we have a very complex diagnosis. We have supracardiac total anomalous pulmonary veins with obstruction in the vertical vein. We also have a DORV with AV canal with an anterior rightward aorta, pulmonary atresia, and then confluent pulmonary arteries, which are fed by a typical vertical ductus arteriosus. So a very complex fetal patient. So at this point, we discussed this patient in our case management conference due to the concern for the obstruction of vertical vein at a relatively early gestational age. We decided that we would bring the baby either to the CICU or directly to the cath lab for intervention after birth, depending on how the patient looked after delivery. Our planned intervention was to stent the vertical vein plus or minus stenting the PDA at the same time versus waiting until a little bit later to stent that PDA. The patient was continued to be followed monthly in our fetal cardiology center. The obstruction remained stable at 4 millimeters of mercury for our gradients, even with maternal hyperoxia later in gestation. So then at 39 and 4 weeks gestation, this mother delivered a female infant by spontaneous vaginal delivery. After intubation really stabilized with saturation. So on our postnatal echo on this subcostal sweep, again, you can appreciate we have our complete AV canal with a near common atrium, which we knew, and we have our confluence here posterior to the left atrium with the flow. Right SVC through the vertical, just proximal to its entry into the right SVC, which was very concerning for obstruction. When we did our arch views, and again, sweeping sort of right to left to see the association, we see that vertical PDA going into the branch PAs, and then almost on top of it, we have all of our turbulence in our vertical vein going into our SVC, which is draining our pulmonary veins. And when we Dopplered our vertical vein at the area where it was obstructed, we now have a mean of 17. Now then the concern for the proximity of the vertical vein and the PDA, we decided it was better to proceed with a CTA before doing any interventions. So these are some 3D CTA reconstructions of both the arterial and venous anatomy. As this comes around, I'll pause it so you can appreciate a little bit better what is going on. So we actually had 3 pulmonary veins from the right and 3 from the left, all draining into this confluence. And then you can see it become the right SVC. So this was did our vertical PDA going on top of each other. Again, you can see here is that hourglass shape where it's narrowed and it's crossing, traversing across the course of the PDA, which is going superior and inferior right here. So because of that close proximity, we felt that stenting of either of these structures was really not going to be feasible, given how close the stents would be together and that they would likely obstruct each other. So the patient was then taken to the operating room to get a complete total veins repair as well as a shunt placement. She's now 6 months old and actually is hospitalized again because she's in the process of getting her Glenn at this point in time. So in summary, we can diagnose total veins on fetal echo, including evidence of obstruction. The full evaluation of that vertical vein can be a bit challenging if you have very complex congenital heart disease, especially things that are ductal dependent for pulmonary outflow, given the close proximity of some of those structures in some cases. And again, the proximity of that vertical vein and that PDA can really at times limit your interventional choices, given the way that they may overlap. And so this is where cross-sectional imaging is very helpful for us to delineate that. Thank you very much.
Cool. Thanks, Stephanie. That was really great. I always love a good, I mean, don't get me wrong, I love my echo, but having a nice CT angio on there is really nice, especially when we're trying to decipher veins. And especially when you're trying to, you see that CT and then you can scan the echo later or post-op or wherever. I feel like that really helps delineate and help for a sonographer as well to be able to use that other imaging modality as well. So those were great talks, guys. I really appreciate everybody's time tonight. If anybody has any questions to throw into the chat real quick. Don't see any questions. I feel like with cases, it kind of tells a story. Bernadette, when that baby came to you, were you guys told anything? Had they echoed or just basically the baby was going to die and
Yeah, it was just really limited info. It was like kids showed up in the ER, want to come with me?
Yes.
Then you see the kid, and we originally thought the sat monitor was wrong, like it just wasn't connected or something, but we also were like, well, this kid is pretty blue. So
I'll say one time I had a case where I can't remember, they came from somewhere when I was in Colorado, and we were told it was a transposition. And my fellow called me when the chopper landed because I was going to help with the septostomy. And she called me a couple minutes into my drive and she said, it's not transposition. And I said, what is it? And she's like, there's a lot of flow. And it was an obstructed supracardiac veins. And so, you know, it's not always what we think it's going to be. So Alice, did you have any questions?
I do have a question for Stephanie, but there was a question that just came up in the chat from Rosie. Bernadette, can you give the name of the volunteer organization again?
sure, it's Heart Care International. And I will copy the link that was on the slide that didn't display into the chat.
Okay, great. And then Stephanie, I was just wondering, you talked about the possibility of stenting the vertical vein, and I was just curious your experience, your institution's experience in doing that, and you know how successful it is in the outcomes when you have obstructed veins.
We have definitely done it kind of in limited cases. I will say I think there's a bit of a selection bias because we probably tend towards stenting the vertical vein where it's obstructed in patients who are more critically ill, who we don't think would do well with a full repair. So the results are a little bit mixed, I think. But again, I think it's from selection bias. We have stented like inside the liver for infradiaphragmatic obstructed veins. We've done it for supracardiac total veins. But again, we're really only doing that if either because of birth weight or because of other factors, we don't think emergent surgery is a good option at that point in time.
Yeah, interesting. Thank you.
Very cool. And I will say that core triatriatum case, I scanned very few in my career. And those are some great images to be able to see the septum in there. And that was an awesome case too, and a good learning opportunity too as well, and how sick those kids can really get too. Okay, so I don't see any other questions in there. Bernadette put the link in for everybody to see for Heart Care International as well. Bailey, can we put the end slides up? Okay, so our next speed session, we did this one a little early due to the holidays, but the next speed session is going to be January 28th. Aortic valve repair and imaging techniques. Carolyn, we have a surgeon coming?
Yes, so we'll have surgeons from Rainbow Babies, and then we'll also have an additional talk from one of our sponsors from Kentucky. So Bailey, if you can put up our sponsor slide again. Again, we like to thank our sponsors for the Society of Pediatric Echo, and thank you everybody for joining us this evening for these 3 great cases.
All right, thanks guys. Have a good holiday. We'll see you guys in January. Cool. Thanks guys. Those are awesome cases. Super great. And they all had good outcomes.
Yeah, I noticed that too. Everyone did well. It was great.
It's way more fun when the babies don't die. Okay, well, we appreciate you guys coming to this and giving a case study for us. We really do. We appreciate the time you guys put into it. So,
Yeah, thank you for inviting me.
yeah.
Yeah,
All right,
this was
guys.
great.
Cool. Thanks, guys.
Have a good evening, everyone.
Good night.
Bye.